Hello and welcome to this three-part lecture series on Chapter 22, Microbial Diseases of the Nervous System. We'll be looking at bacterial, viral, fungal, protozoan diseases of the nervous system. Again, it's a three-part series. It's mainly intended for my college students, but of course anybody who's interested in diseases of the nervous system can benefit from this lecture, I'm sure. So let's get started. So microbes can enter the nervous system via a few different routes. Skull or backbone fractures, so the bone breaks, there's some tear in tissue. Microbes can now enter, so they have a portal of entry to get into the nervous system. Medical procedures can lead to the entrance of microbes as well, just because of the cutting of tissue. So surgical procedures can allow this to happen as well, along with the parenteral route or puncture wounds. Along peripheral nerves, such as the case with rabies, for example, where the virus travels along peripheral nerves, makes its way into the central nervous system, eventually to the brain, or through the blood or lymph. If, say, for example, with West Nile virus, you're bit by an infected mosquito and the viruses enter your bloodstream, can cause encephalitis in the brain then later. So these are just a variety of different ways. Now, there are protective measures, of course, around the nervous system, especially the central nervous system, that prevent microbes from getting in there. But when they do, they can oftentimes be devastating because of the lack of immune defenses that we have within the central nervous system itself. So this is kind of what the nervous system looks like, especially the one on the right. It's from an actual person. This is a picture of a person that was on display in the bodies exhibit, and a body exhibition that was on display, and it was on tour in Europe and in North America, as well as a few other parts of the world, from early 2000s till about 2012 or somewhere around there, where these bodies, which were deceased individuals, were put on display, and they were dissected in a variety of different ways, somewhat disturbing but fascinating ways. And they were on display in the open air. These bodies could be touched. They didn't need a preservative because they were preserved through a process called plastination, in which the water and the fat is removed basically from the tissue and replaced with plastics. And this then preserves the shape, it preserves the integrity, but at the same time there's no need for a preservative, and so these tissues don't rot, they don't smell, they don't stink, they don't smell bad. I've been to one. I was at one in Pittsburgh a number of years ago. There's no stink to them at all. That's not like a preservative smell or a rotting smell. It's just they're just basically plastics, and it was developed by a German anatomist named he was developed this in 1977. Gunther von, oh, I can't remember his last name. I remember his first name though, Gunther, because it's so cool. But he was an anatomist, developed this process in 1977, a process called plastination, and you can see it looks pretty fascinating, where you can see the peripheral nerves all converging into the spinal cord and then up to the brain as well. So what are some of these diseases? Well, we'll look at bacteria first. Bacteria can grow in the cerebrospinal fluid in the subarachnoid space. So we have three meninges. There's the outermost one called the dura mater, the middle one called the arachnoid mater, and the inner one called the pia mater. And in between the arachnoid and pia maters, there is a space that is called the subarachnoid space. And within that space, there is this fluid called cerebrospinal fluid. It is almost entirely water, but it has some dissolved compounds in it as well that are used to nourish the central nervous system, but are also used to cleanse the central nervous system as well. In an adult human, there's about 150 milliliters of cerebrospinal fluid that's circulating around the brain and the spinal cord. We produce in the course of a day about 700 milliliters of cerebrospinal fluid, and again, it's almost 99% water. And it has a number of functions. But within that cerebrospinal fluid, this is where the bacteria can grow, and this is where they can multiply and divide and then cause the devastating effects that they have. And in cerebrospinal fluid, we have very few immune system cells. There's very little complement, there's very few antibodies, and so therefore we're susceptible. Fortunately, though, it's very difficult for microbes to get into the cerebrospinal fluid. because of the protective measures that we have in place around the cord and the brain. The blood-brain barrier is a set of capillaries that prevents passage of some materials, such as antimicrobial drugs, into the central nervous system. And in order to pass through the blood-brain barrier, these things must be lipid-soluble. So the blood-brain barrier, a set of capillaries, it's part of the circulation of the body, and they have these tight cellular junctions between them, and they let these capillaries let very few things get through them into the delicate neural tissue that they are traveling through. And so some bacteria have actually, I don't want to say adapted, but because it's kind of confusing how they're able to do this, but some bacteria can leave the blood circulation, exit the blood-brain barrier, and then get into cerebrospinal fluid and into spinal cord tissue and brain tissue, and cause their problems, release their toxins, and cause these diseases, meningitis, encephalitis, and a combination of the two, meningoencephalitis, which is the inflammation of the meninges and the brain both, which is obviously a life-threatening situation. So this is what I was talking about with you can see it visually here. We have if you look at the picture in the upper right, there's you have the skull bone, then you have the dura mater, and then you have the arachnoid mater, and then there's the space, and that's the subarachnoid space, which has the cerebrospinal fluid, and then the pia mater is a very delicate, thin layer of tissue, squamous cells that go down into the sulci of the brain and go up over the gyri as well and just cover it. And within that space, that's where the cerebrospinal fluid is found, and that's where the blood-brain barrier capillaries are as well, traveling through that space. And this is where the pathogens will grow, in that subarachnoid space. So we'll look at meningitis. So bacterial meningitis accounts for about 70% of all cases of meningitis. Sorry, I need to rephrase that. 70% of all cases of bacterial meningitis are caused by only 3 species of bacteria. So the remaining 30% are caused by other species. So these 3 they're the ones that are notorious for causing bacterial meningitis. And the reasons why is because they have adaptations that they can utilize, and the toxins that they produce are severe to the nervous system. What are some symptoms? Fever, headache, stiff neck, nausea, vomiting, and it could progress to convulsions and eventually into a coma. Death occurs quickly due to release of endotoxins and/or cell wall fragments. And so fragments from the bacterial cell walls get released into the cerebrospinal fluid, and this causes shock and inflammation. So we can have a severe decrease, an uncontrollable decrease in blood pressure. How do we find out? Well, we gram stain the CSF. So do a spinal tap. So the medical procedure that's done is they'll do a lumbar puncture. They'll go down below around L3, and they'll aspirate some of the cerebrospinal fluid, gram stain it, look at it under a microscope, and be able to identify the bacteria there. Treated with cephalosporins and vancomycin, and about 10,000 cases are reported annually in the United States. Many, many more, of course, globally, but in the United States, about 10,000 cases. And this is my students can click on this in their PowerPoint, the meningitis hyperlink, and it just gives a brief explanation of meningitis and some of the signs and symptoms that accompany meningitis. So these are the 3: Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. These are the 3 bacterial species that are causing the 70% of bacterial meningitis cases. And then I wanted to mention down there with the Hib vaccine. The Hib vaccine refers to the Haemophilus influenzae type B. That's the abbreviation HIB vaccine. It accounted for about 45% of cases of bacterial meningitis. Now look where it is. It's down to about 2 to 7% of all cases that are from these 3 species. So the vaccine was most definitely effective. The Hib vaccine was an excellent one, very successful vaccination against this particular species. And you'll notice the name of that, Haemophilus influenzae, and you see that influenza. It was mistakenly thought to be a bacterium that caused influenza, which it doesn't. The influenza viruses, they cause influenza, not this bacterial species. But in some cases, meningitis can appear, at least at first, like it's influenza. So it has influenza-like symptoms. So it was mistakenly thought that it was a causative agent for influenza, but it's not, but the name has stuck. And so now it remains Haemophilus influenzae, and it doesn't cause influenza. Um, Streptococcus pneumoniae, now that can cause pneumonia, but it can also, when it's in the respiratory tract and in the lungs, but it causes meningitis as well. Haemophilus influenzae, so this would be the one that we were talking about with the Hib vaccine type B, occurs mostly in children, about 6 months to 4 years old, in that age range. It's a gram-negative aerobic bacterium, so it requires oxygen, and it's found in normal throat microbiota. So many people are carriers of this particular bacterium. It has a carbohydrate capsule, and that thick capsule increases its pathogenicity and makes it difficult to be phagocytized by white blood cells. And the Hib vaccine is very, very effective. It's given at 2 months, 4 months after birth, and possibly 6 months, and it depends on the brand of the vaccine. The one brand, only 2 and 4 month administration, and another brand of the vaccine, 2, 4, and 6 month vaccination. And so I just wanted to show you a graph, and this is the typical graph of so many vaccinations, so many vaccines, where the pre-vaccine era, the number of cases, it's way up. As you can see, the red line is showing how many there are, and then the polysaccharide vaccine was administered between 1985 and 1988. A better one was developed, a conjugate one that was conjugated with protein. So we have the carbohydrate protein conjugate vaccine put together, and that's been given since 1988. And you can see as the number of doses increase of the vaccine, the amount of cases just drop off precipitously. It's like jumping off a cliff. And so this is another of the many success stories of vaccines and how effective they are at preventing disease. And that graph has continued to go down. So as long as the number of doses remain high, the number of cases remains incredibly low. Once the number of doses begins to decrease, that graph will start to go up. As we see with pertussis, people are not getting the pertussis vaccination, and as a result of that, the number of doses decreases, and now the number of cases of pertussis in the United States is going up. And it's a very frustrating thing to see. You have all this evidence, all these graphs, all these numbers, and yet people are choosing for one reason or another to not vaccinate their children. But anyway, I digress. Neisseria meningitidis. This is also called meningococcal meningitis as well. It occurs mostly in children. It's during that vulnerable time period when the immune system is starting to develop antibodies and recognize pathogens. And so this is a vulnerable time for us. Gram-negative aerobic cocci, so these are spherically shaped bacteria. They have a carbohydrate capsule as well that increases their pathogenicity, like with Haemophilus. 10% of people are healthy nasopharyngeal carriers, so 10% of the human population is carrying this particular bacterium in their nasopharynx region. And it starts as a throat infection and a rash caused by an endotoxin. So some people will present with, they think it's just a sore throat. In many cases, they think it gets painful enough that they think it might be strep throat. So we have two different bacteria that are presenting these symptoms in similar ways, and this is where the confusion comes about. And of course, you don't want to develop meningitis, so it needs to be diagnosed correctly. This is the one that we hear about when you hear about outbreaks in colleges because of crowded dorms, where the bacteria are being shared among the residents within a dormitory, and it gets spread that way through that dense population. It may become septic and lead to tissue destruction as well, so it can get into and grow within the tissue of the body, and then that can lead to sepsis and the breakdown um, of, uh, of connective tissue. Vaccine against some serotypes is available, and the vaccine is given at 11 or 12 years old, then a booster at 16 years old as well. And this is what they look like. The hairy cells, those are the ciliated cells of the respiratory tract, and these are where the Neisseria, where they grow in these spherical clusters that are growing in the nasopharynx region there. Pneumococcal meningitis, gram-positive diplococci with a capsule, and it is the leading cause of meningitis. 70% of people are healthy nasopharyngeal carriers, and so you can see why it's the leading cause because 7 out of 10 people are carrying these bacteria in their nasopharynx region. Most common in children, again, during that vulnerable time, 1 month to 4 years old. And what's scary about this one is it has a high mortality rate, 30% in children, 80% in the elderly. Fortunately, we have a very effective vaccination. It's a conjugated vaccine. It's given at 2, 4, and 6 months with a booster at 12 to 15 months. So it kind of follows the pertussis vaccination, the Tdap vaccination, the tetanus, diphtheria, and pertussis vaccination. These are kind of given simultaneously. This bacterium, though, is becoming increasingly antibiotic resistant, and being able to evade antibiotics, and the antibiotics are not effective against it. So more antibiotic research needs to be done against this particular bacterium. Well, that's it for part one. Again, this is a three-part series, so I have two more parts coming up, so please stay tuned for that, and thank you for watching.